Hello everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Alae Aboussekhra, your host for today's episode, and I'm joined by my dear friend Lyan Tawfik to discuss two critical neurological conditions, meningitis and encephalitis.
Hey everyone, and thank you so much, Alae. Meningitis and encephalitis are quite the important topics. Understanding the differences between the two and their management is crucial for healthcare professionals. Why don't I start off with the case and we'll see where the wind takes us?
Sounds good. Let's get started.
For today's case, we have a 25-year-old male who presented to the emergency room with a sudden onset high fever, severe headache, and neck stiffness. He also was squinting in the ED, commenting about how painfully bright the lights were. His roommate says that he has been feeling unwell for a couple of days with flu-like symptoms.
Sounds like meningitis to me, especially when you mentioned the neck stiffness and photophobia. Tell me about his exam findings.
Exactly. This patient likely has meningitis or inflammation of the meninges. On physical exam, he was lethargic and confused with a positive Brudzinski sign, which is when passive neck flexion causes involuntary hip and knee flexion. A lumbar puncture was performed, and CSF analysis showed increased white blood cells, elevated protein, and low glucose levels.
Right. The picture of meningitis is really coming together even more now. Any idea how he might have gotten this to begin with?
Likely from an initial infection. His roommate did mention flu-like symptoms earlier.
Seems like an awful jump from a standard flu. The golden question is, though, how did it reach his nervous system?
That's a really good question. I have the golden answer. Strap in, because we've got a lot ahead of us. There are four main routes for pathogens to cause meningitis. First, it could be due to colonization of the nasopharynx, or birth canal, in infants. Pathogens would invade the bloodstream and cross the blood-brain barrier. Second, and most commonly, is the hematogenous spread, where pathogens in the blood infect the CNS directly. The third route is via direct inoculation, which is usually due to trauma or neurosurgical procedures. Finally, it can be a contiguous spread, where pathogens hop on from nearby infections like sinusitis or otitis media.
Got it. So, colonization, hematogenous spread, direct inoculation, and contiguous spread. All right, Lyan, we've covered a lot about meningitis, but I'm curious. After it gets in the brain, how does the infection actually cause damage? Can you walk us through that?
Absolutely. Let's break it down step by step. After successfully evading the immune system, crossing the choroid plexus and damaging the endothelial layer of blood vessels, and finally making their way to the CSF, pathogens are relatively safe from the body's immune system and can now multiply freely. Next, we have the formation of edema. This is when the infection causes increased permeability of the BBB and causes swelling in the brain. The infection can also cause endothelial injury, which might progress to thromboembolism, blood clots that can block blood flow. All of these factors combined, increased permeability, edema, and endothelial injury, leads to a rise in intracranial pressure, or ICP. High ICP can cause severe complications, including brain herniation, if not managed quickly.
Okay, that makes sense. And how do the different pathogens fit into it?
So, meningitis can present across a spectrum of time frames. First, we have acute meningitis, where symptoms develop within hours to days. The most common causes are viral agents, like Enteroviruses such as Coxsackievirus or Echovirus, and herpes simplex virus, or HSV2. For bacterial agents, we have Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenza type B. We also have subacute meningitis, which is when symptoms evolve over days to weeks. Some notable causes here would be bacteria such as Mycobacterium tuberculosis and, in immunocompromised patients, a fungi called Cryptococcus neoformans. Finally, chronic meningitis occurs when symptoms persist for more than 4 weeks. Causes of this could be bacteria like Mycobacterium tuberculosis, fungi like Histoplasma capsulatum, and Cryptococcus neoformans, and parasitic agents like Toxoplasma gondii and Naegleria fowleri.
Can I just say that Neisseria meningitidis has such an appropriate name?
I know, right?
Now that we've discussed the timeline and the common pathogens involved in meningitis, why don't we dive deeper into each pathogen, starting with the bacterial agents? Can you break them down for us?
It would be an honor, Alae. Let's go pathogen by pathogen, starting with one of the most notorious, as you've said, appropriately named Neisseria meningitidis. So, Neisseria meningitidis is a gram-negative diplococcus that's transmitted through respiratory droplets. It's infamous for causing community-acquired meningitis and can also lead to meningococcemia, a life-threatening form of sepsis.
Okay, so it's a gram-negative diplococci, which means that it occurs in pairs. And how does it end up causing the disease? Any significant features or virulence factors we should watch out for?
Yep, some of its key features include a polysaccharide capsule that prevents phagocytosis, allowing it to evade the immune system. It also has IgA protease that degrades IgA antibodies, aiding in the colonization of mucosal surfaces. It also has pili, which help it to adhere to nasopharyngeal cells, and endotoxins, lipopolysaccharides, which trigger septic shock and inflammation. Another important feature of this pathogen is that it's classified into 6 main serogroups: A, B, C, W135, X, and Y, with B, C, and Y being common in developed countries, while A and W135 are prevalent in developing regions. The good news is that meningococcal vaccines cover these serogroups, but serogroup B requires a separate vaccine.
Oh, that's a relief. Any complications of this pesky bug that we should keep in mind?
Yes, it can cause petechial rashes and a severe complication known as Waterhouse-Friderichsen syndrome, which is adrenal hemorrhage due to the endotoxins.
Oof, that sounds intense. All right, what's next on our bacterial agenda?
Next, we have the infamous Group B Streptococcus, or GBS. This one is a gram-positive cocci found in short chains. It's a leading cause of neonatal meningitis and is typically transmitted during birth from the mother to the child.
Got it. So when I think of GBS, I should always think babies. What are some important features we should know?
Some key features are that it is a catalase negative and CAMP test positive, and you really want to watch out for those because they can try to confuse you with it in the exam questions.
Okay, I promise I won't forget it. What else about its structure?
Well, this bug also has a capsule, preventing phagocytosis by masking surface antigens, and it has hemolysin, which contributes to tissue invasion and damage, and adhesins that help attach the epithelial cells in the birth canal. It often colonizes the genital and gastrointestinal tracts of humans. And I hate to disappoint you, Alae, but we don't have a vaccine here. However, maternal screening and administering interpartum antibiotics significantly reduce the risk of neonatal infection.
You're right to predict my disappointment. I heard that it's the most common cause of bacterial meningitis in neonates, so it's a good thing we at least have screening programs. Anyway, I think that covers Group B strep. What's next?
That would be Listeria monocytogenes, a gram-positive rod known for its tumbling motility and ability to cause meningitis in neonates, pregnant women, and the elderly. It's typically acquired by eating contaminated food like unpasteurized dairy products.
So this is why we tell pregnant women not to eat deli meats then. Why don't we just put the turkey in the fridge? Isn't that supposed to prevent food from spoiling?
Unfortunately, this bug in particular grows well even at low temperatures, so throwing the turkey and mayo sandwich in a fridge won't put a dent in it. Also, I want to mention that it is a facultative intracellular pathogen, meaning it can survive and replicate inside host cells.
This really is a tough one to crack. And what about the virulence factors of this deli meat-loving bug?
That would be Listeriolysin O, which would allow it to escape from phagosomes into the cytoplasm, and internalins, which promote entry into non-phagocytic cells. One more thing to know about Listeria monocytogenes is that infection in neonates can occur transplacentally or during delivery, and that it can cause granulomatosis infantiseptica, a severe neonatal infection with abscesses and granulomas.
Yikes, that was a lot. I would hate to give up turkey and mayo sandwiches. Alright, what about the classic cause of bacterial meningitis, Streptococcus pneumoniae?
Yes. Streptococcus pneumonia, a gram-positive diplococcus that's catalase negative, bowel-soluble, and optogen sensitive.
Got it, so it occurs in pairs just like Neisseria meningitidis, except this one is gram-positive, not negative. And what makes this bacteria so dangerous?
Well, Streptococcus pneumonia is a leading cause of community-acquired meningitis. In fact, over 90 serotypes have been identified based on its capsular polysaccharide, and because of this, it's particularly dangerous in asplenic patients.
Oh, why is that?
Normally, the spleen is able to opsonize and phagocytose encapsulated organisms, but with no spleen, the body loses that function completely, and these patients become especially prone to infections by encapsulated organisms such as Streptococcus pneumonia.
Okay, that makes sense. And what else about it makes it dangerous?
This bacteria is also known for causing fulminant course of meningitis, meaning that it has an abrupt onset, rapid deterioration, and high mortality. Its virulence factors include the presence of a capsule, which is essentially for avoiding phagocytosis, IgA protease, which helps it colonize mucosal surfaces, pneumolysine, which causes damage to epithelial cells and inhibits the immune response, and finally, autolysin, which causes the release of cell wall components to trigger inflammation.
All right, so a capsule, IgA protease, pneumolysine, and autolysin. Easy enough. I've always found it interesting how these organisms develop all these ways to evade our immune systems. It almost sounds like something out of a sci-fi movie. Anyway, I sure do hope there's a vaccine for this. It seems like a pretty intense infection.
Well, I have great news for you, Alae. Vaccination with PCV13 for children and PPSV23 for adults has significantly reduced cases.
Whoa, that's a relief. Last but not least of the bacterial causes, tell us about Haemophilus influenza type B.
Haemophilus influenza type B is a gram-negative coccobacillus that's oxidase positive. It was once a leading cause for meningitis in children, but has become much less common due to vaccination.
Right, I think I heard about that. And what are some more of its key features? Like, how can I immediately recognize that this is probably a Haemophilus influenza infection?
Some of its key features that are a huge giveaway are that it requires factor 10, hemin, and factor 5, NAD, for growth, and also that it grows on chocolate agar but not on blood agar without these factors.
Chocolate agar sounds misleading to what it entails. Tell me about the virulence factors.
So much like the other bacterial causes we discussed, it has a capsule made of polyribosylribitol phosphate, which resists phagocytosis. It also has IgA protease, and that enhances survival on mucosal surfaces. Finally, it has pili that help it to attach to respiratory mucosa.
All right, cool. So we have a capsule, IgA protease, and pili. What about vaccination?
For vaccination, the HIP vaccine has led to a spectacular reduction in meningitis cases. Before vaccines, it was a leading cause of bacterial meningitis in children under the age of 5.
That's really great news. Now, before we wrap up bacterial causes, tell me, how would we go about managing them?
So when it comes to management, bacterial meningitis is a medical emergency and requires immediate empirical antibiotic therapy. That could be ceftriaxone plus vancomycin, which covers most common bacterial pathogens. However, if we suspect Listeria to be the cause, we would add ampicillin to the mix, particularly if the patient is a neonate, elderly, or generally immunocompromised.
Okay, so it's all about being safe and covering your bases with broad-spectrum antibiotics like ceftriaxone and vancomycin, and plus ampicillin for Listeria, of course. Well, Lyan, let's just say someone came in close contact with a patient with meningococcal meningitis. What would they take in that case?
That's a really good point. Thank you for bringing that up. In that case, we would administer prophylaxis in the form of rifampicin, ciprofloxacin, or ceftriaxone.
It's relieving to hear that there's a protocol for such a case. Prevention is really better than cure.
Yep. Now, before we wrap up bacterial causes, I'd like to give a shout out to some of the vaccination strategies.
Yay, my favorite.
Vaccination strategies include meningococcal conjugate vaccine, MCV4, which covers serogroups A, C, Y, and W135, meningitis C conjugate vaccine, which is used in the UK, the pneumococcal vaccine such as PCV13, PCV15, and PPSV23, which help to prevent S. pneumonia infections, and finally, the HIP vaccine, which prevents H. influenza type B meningitis.
Thank you for that. That was truly a mouthful. Get vaccinated, everyone. I certainly am on a meningitis roll. So why don't we jump right into discussing viruses?
Love to see the excitement, Ella. Hope this energy persists to the end of this episode. Let's begin with Enteroviruses, the leading cause of viral aseptic meningitis. Despite their name, they rarely cause enteric disease but replicate in the GI tract and spread via the fecal-oral route. However, Coxsackie and Echoviruses can also be transmitted through aerosols. They are most common in children under the age of 5, peaking in summer and fall. While typically mild, they can be severe in immunocompromised individuals. Their capsid proteins help them survive the harsh GI environment, and their tissue tropism allows them to infect multiple organs, including the CNS, heart, and the skin.
They seem to be rather resilient. I can see why they're so common. Who's our next player?
That would be Coxsackievirus, a member of the enterovirus group, known for causing meningitis and encephalitis. We split it into two groups, Group A and Group B, and they each cause a different set of diseases.
What's Group A known for?
Group A primarily causes aseptic meningitis, febrile illnesses, herpangina, which is a vesicular enanthem in the posterior pharynx. Contrast this with herpes, which affects the front of the mouth, hand, foot, and mouth disease, which are vesicular lesions on the hands, feet, and inside the mouth, most commonly caused by Coxsackievirus A16.
Okay, and what about Group B?
Group B is associated with more systemic and severe conditions like neonatal disease, Bornholm disease, epidemic pleurodenia, myocarditis and pericarditis, hepatitis, aseptic meningitis, more commonly caused by Coxsackie B than Group A.
Speaking of meningitis, how does Coxsackievirus compare to other causes?
Aseptic meningitis is inflammation of the meninges without bacterial infection, often caused by viruses. Here's how Coxsackie A versus B compare. Coxsackievirus B is more likely to cause aseptic meningitis. Infants under 12 months have the highest risk. Fortunately, long-term neurological deficits are rare in recovered infants.
All right. Could you tell us more about the pathogenesis?
So the process unfolds in stages. Primary viremia, the virus replicates in the oropharynx and GI tract before entering the bloodstream. Secondary viremia, it spreads to target organs like the CNS, heart, and the skin. Key virulence factors include capsid stability, allowing it to survive in the GI tract, and broad tissue tropisms targeting CNS, skin, and the heart.
And what about the symptoms?
Aside from meningitis, Coxsackie A can cause myocarditis or pericarditis if it infects the heart and maculopapular rash on the face. Also, it has no vaccine, so prevention relies on your hygiene.
And how would we go about diagnosing this exactly? I know that CSF samples with decreased glucose, increased neutrophils, and increased intracranial pressure would indicate bacterial meningitis. Would it differ here?
Alright, so first, the best approach to diagnose is via RT-PCR of CSF, which detects viral RNA, stool samples since Coxsackievirus is fecal orally transmitted, and as you've mentioned, lumbar puncture findings, which in the case of viral meningitis would show elevated lymphocytes, normal glucose, and slightly elevated protein.
Wow, Coxsackie A is no joke. Its ability to affect multiple systems is both impressive and a bit unsettling. All right, Lyan, let's zoom out and talk about the general pathogenesis of viral meningitis. How do these viruses actually cause inflammation in the meninges?
That's a good question. Here's how it works. The process of viral meningitis begins when viruses enter the body through the oropharynx and GI tract. Once inside, they replicate within the mucosal and lymphoid tissue of the pharynx and the tonsils. These viruses are equipped to withstand the harsh acidic environment of the stomach, allowing them to move further into the intestines. As the infection progresses, the viruses enter the bloodstream, leading to primary viremia, where they disseminate to various organs. At this stage, tissue tropism determines which specific tissue the viruses will infect. For example, poliovirus binds to receptors on the muscle cells and neurons, while Coxsackie and Echovirus exhibit a broader range, affecting the CNS, heart, and the skin. Following this, secondary viremia occurs, during which the virus crosses the blood-brain barrier and invades the meninges. Once inside the CNS, the virus undergoes cytolytic replication, causing infected cells to lyse and release more virions, furthering the infection and leading to inflammation of the meninges. We should also note that unlike bacterial meningitis, Viral meningitis is typically self-limiting and less severe.
Got it. So the key difference seems to be that viral meningitis is usually less severe and self-limiting compared to bacteria. That's definitely reassuring. Let's wrap this up with some prevention strategies. How can we prevent viral meningitis?
Unfortunately, there are no vaccines for Coxsackieviruses or echoviruses, so prevention focuses on your hygiene, frequent hand washing with soap, especially after using the toilet or changing diapers, and avoid sharing utensils or personal items. Enteroviruses are resistant to most disinfectants but can be inactivated by formaldehyde, hypochlorite, and chlorine, so we keep that in mind if we try to use disinfectants. Also, isolate infected individuals during the acute phase to prevent the spread. And finally, reducing overcrowding and improving ventilation can minimize transmission risks.
What about polio? Its vaccine is revolutionary.
While the polio vaccine can prevent polyvirus-induced meningitis, it cannot prevent other enterovirus types.
So it sounds like good hygiene and environmental controls are our best bets for preventing viral meningitis. Now, let's move on to fungi. The fungi.
You must feel so clever with that pun, Ella, but I'll ignore it. Alright, let's start with Cryptococcus neoformans. The pathogen responsible for cryptococcosis, particularly cryptococcal meningitis, it is considered the most common and life-threatening invasive fungal disease worldwide.
Lyan, I'm hilarious, and you know it. So, what are the main features and how is it transmitted?
Yeah, right. Let's break it down. Cryptococcus neoformans primarily infects the lungs, making it a respiratory pathogen at first. It's strongly associated with bird droppings, particularly from pigeons, which serve as a reservoir. Transmission occurs through inhalation of the fungal spores, but there's no human-to-human spread, meaning it's not contagious between people. A key distinguishing feature of Cryptococcus neoformans is its oval, budding yeast form, which is surrounded by a large polysaccharide capsule. This capsule is not only antigenic, but also plays a crucial role in evading the immune system.
Got it. But who's most at risk for cryptococcal meningitis?
The infection is especially important in AIDS patients due to their low CD4 cell counts.
Once we suspect cryptococcal meningitis, how do we confirm the diagnosis?
So, diagnosis relies on identifying the fungus and its capsular antigen using the following key tests. Firstly, India ink staining. When spinal fluid is examined under a microscope, Cryptococcus neoformans appears as an oval yeast with a wide unstained capsule against a dark background. Then, periodic acid shifts, or PAS stain. If a tissue biopsy is taken, this stain highlights fungal cell walls, aiding in histopathological diagnosis. And finally, cryptococcal antigen test. This test detects the capsular antigen in spinal fluid using latex particular agglutination, making it highly effective for identifying high antigen titers.
So the capsule really comes in handy for diagnosis, not just for evading the immune system like a bandit in a ski mask. And last but not least, let's talk about tuberculosis meningitis.
You're really on a roll, Ella. TBM is caused by Mycobacterium tuberculosis and is a common cause of chronic meningitis in developing countries. The infection typically begins in the lungs, where the fungal spores are inhaled. From there, it spreads through the bloodstream to the central nervous system. Once it's in the brain, it forms rich foci and caseous lesions, which can rupture and lead to basilar meningitis. A thick, gelatinous exudate develops, which can obstruct cerebrospinal fluid flow, resulting in obstruction hydrocephalus and cranial nerve palsies. Now let's talk about its virulence factors, the tools it uses to survive and spread. Mycolic acid helps it resist phagocytosis and evade immune clearance. Also, cord factor prevents phagosome-lysosome fusion, allowing the fungus to persist inside immune cells. Clinically, the infection has a gradual onset, with symptoms like headache, fever, vomiting, and altered mental status. One of the hallmark findings is cranial nerve palsies, which can lead to neurological deficits.
Okay, so it stealthily spreads from the lungs to the brain, evades the immune system, and then causes serious complications like hydrocephalus and nerve damage. That's quite the invasive strategy. Lyan, I have a confession to make.
I'm listening.
The role I was on has faded. Can you give us a quick recap, Lyan?
Understandable. Anyone would feel the same. Alright, let's start with the basics. So, meningitis is the inflammation of the meninges, the protective layers around the brain and the spinal cord.
And meningitis can be caused by bacteria, viruses, fungi, or even tuberculosis. Bacterial causes are usually the most urgent to treat.
You're right. And for bacterial meningitis, the main culprits are Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenzae. These bacteria use capsules and toxins to dodge the immune system and cause severe symptoms like fever, neck stiffness, and alter mental status.
In contrast, viral meningitis is usually less severe and is often caused by enteroviruses like Coxsackie and echovirus spreading through the fecal-oral route. And when it comes to CSF findings, bacterial meningitis usually shows high neutrophils, high protein, and low glucose, while viral meningitis shows more lymphocytes, normal glucose, and slightly elevated protein in the CSF.
Now, for fungal causes, cryptococcal meningitis is a big one, especially dangerous for AIDS patients due to their low CD4 counts. It spreads by inhaling spores from bird droppings and can be diagnosed with the India ink stain or the cryptococcal antigen test.
Then there's tuberculosis meningitis, which is slower in onset and shows high protein, low glucose, and a mix of lymphocytes and polymorphs in the CSF.
When it comes to treatment, bacterial and fungal meningitis need immediate antibiotic or antifungals, while viral cases are mostly about supportive care. And unfortunately, there are no vaccines for viral types like Coxsackie, so prevention relies on good hygiene and avoiding exposure.
But for bacterial causes, vaccines against N. meningitidis, H. influenzae, and S. pneumoniae can really help prevent outbreaks.
Exactly. So the key to managing these infections is early diagnosis, targeted treatment, and, where possible, vaccination.
All right, I think we covered a lot. Thanks for helping us break it down, Lyan.
Anytime, Alae. That was a solid team effort.
Now that really ties everything together. I feel slightly less lost now. So the main takeaways are recognizing the CSF patterns, knowing the key pathogens and their virulence factors, and understanding the importance of vaccination and hygiene. All right, Lyan, we've covered meningitis in detail, but we can't forget its close cousin, encephalitis. Can you give us a quick rundown on what it is and how it's different from meningitis?
Encephalitis is the diffuse inflammation of the brain parenchyma.
So, if I got this right, the main difference is that meningitis inflames the meninges, while encephalitis affects the actual brain tissue itself.
Yes, exactly.
Okay, and what is encephalitis usually caused by?
The most common causes of encephalitis are viral infections like herpesviruses and flaviviruses.
All right, let's start with herpesviruses. They seem to cause a lot more than just cold sores. What's the big picture here?
Herpesviruses are a group of DNA viruses that can cause a bunch of diseases, ranging from cold sores to encephalitis. One of their most important features is latency. So basically, they can hide in nerve cells, and then later on in life, especially during times of stress or immunosuppression, they may reactivate and cause issues.
Okay, Lyan, let's focus on HSV2 for a moment. I've heard it's more common in newborns. Is that true?
Yes, that's correct. Herpes simplex virus type 2 is more common in newborns because they can get infected during birth if they pass through a birth canal that is already infected with genital herpes.
Wow, that sounds dangerous. How do doctors prevent that?
Great question. Since neonatal herpes can cause severe encephalitis, it's very important that doctors check the mother for active vesicular lesions before delivery. If they do find an active lesion, they should recommend a C-section to avoid exposing the baby to the virus.
Okay, that makes sense. What about varicella-zoster virus? That's also a herpes virus, right?
Exactly. Varicella is one of the herpes viruses. Now you may know the varicella-zoster virus is responsible for both chickenpox and shingles. After causing chickenpox, varicella can go latent in the dorsal root ganglia and reactivate later as shingles. In rare cases, though, it can also cause encephalitis, especially in unvaccinated children between the ages of 9 and 16. When that happens, varicella encephalitis typically affects the temporal lobe, and you can actually see these clinical lesions in the temporal lobes on MRI.
Okay, so varicella encephalitis affects the temporal lobe. Now tell us, how do we treat these infections caused by herpes viruses?
For HSV, minor vesicles usually resolve on their own in 2 to 3 days without any treatment, but generally the go-to treatment is acyclovir. It's effective if started early, especially for HSV encephalitis. However, unfortunately, the overuse of acyclovir patches has led to resistance in a lot of HSV strains. Then, for varicella, there's unfortunately no antiviral drug available, but thankfully, there's a highly effective vaccine. When it comes to CNV and EBV, which are two more members of the herpes virus family, there's no vaccine for either one. Also, unfortunately, EBV doesn't have any specific drug that can be used for it. For CMV, though, we can use ganciclovir, especially in transplant patients and nephrology cases.
All right, Lyan, I think we're good to go when it comes to herpes viruses. Now, let's move on to Flaviviruses. I know they can cause some serious problems too. What's their deal?
Flaviviruses are small to medium-sized single-stranded RNA viruses that can cause both meningitis and encephalitis. Some known examples are West Nile virus, Japanese encephalitis virus, and St. Louis encephalitis virus. It's also important to remember that flaviviruses are vector-borne and are mostly spread by mosquitoes.
Okay, let's start with the first one, West Nile virus. Does it also spread by mosquitoes like the rest of the flaviviruses?
Yes, it does. West Nile virus is mainly transmitted by mosquitoes, actually. However, what's quite interesting is that its transmission cycle is a bit complex, which is why it's difficult to pin down a single term for its zoonotic distribution. But what is known is that horses and birds are both intermediate hosts and reservoirs for West Nile virus. Then, humans and horses are considered incidental hosts, which basically means they don't contribute to the spread of the virus.
That does sound complicated, but I was wondering, how does West Nile virus typically present in patients?
Most West Nile virus cases are actually asymptomatic.
So people might not even realize they're infected?
Yeah, exactly. But for those who do show symptoms, they most commonly present with flu-like symptoms. And actually, only a minority of cases infected with West Nile virus would progress to meningitis or encephalitis. One symptom that can be seen in West Nile virus infections is a skin rash, but as you may guess, a rash may be seen in many other infections, so it's too vague for a definitive diagnosis. One of the most important things to consider when diagnosing West Nile virus is the epidemiology, and what I mean by that is basically the patient's history of mosquito exposure or travel to endemic areas in the US.
Okay, so patient history is very important in this case. Now, should we move on to talk about the Japanese encephalitis virus?
Sure. Japanese encephalitis virus is another vector-borne virus that is, again, mainly spread by mosquitoes. It follows an endozoonotic cycle with birds as a key part of transmission. Like West Nile virus, horses and humans are incidental hosts for Japanese encephalitis virus. From its name, you can guess that it's mostly found around the Chinese Sea.
Again with those mosquitoes. Is Japanese encephalitis more severe than West Nile virus?
It definitely is more severe. Almost all cases are asymptomatic, but when symptoms do appear, they can be devastating. In fact, the mortality rate can go up to 30% for symptomatic cases, and even for those who survive, the outcome isn't great because almost half of them can have serious neurological and psychiatric issues. Even though there's no specific antiviral treatment for Japanese encephalitis virus, the good news is that it has a highly effective vaccine.
Okay, now let's talk about the final member of the flaviviruses trio, which is the St. Louis encephalitis virus.
Like all the other flaviviruses we talked about today, St. Louis encephalitis virus is also spread by mosquitoes and involves a similar transmission cycle. Again, horses and humans are incidental hosts, and then birds are amplifying hosts, which basically means that they're there to maintain the virus in nature. The symptoms seen in St. Louis encephalitis infection are similar to West Nile and Japanese encephalitis, ranging from flu-like symptoms to severe meningitis or encephalitis.
But wait, if they all have such similar symptoms, how can we figure out what's causing the encephalitis?
In the past, we used a syndromic approach, which basically means diagnosing based on signs and symptoms. But now, we can use a molecular approach where we use a single sample to test for bacterial, viral, parasitic, and fungal agents all at once.
That sounds pretty cool. So it's faster and more accurate. And what kinds of infections can this new method find?
This molecular approach can detect viruses like herpes simplex 1 and 2, fungi like Cryptococcus, and finally bacteria like Haemophilus influenza, Listeria, Neisseria meningitidis, and Streptococcus pneumonia.
Okay, great. That really gives us a nice idea about viral encephalitis. Now, how about we talk about something a little different? What can you tell us about prions?
Prions are a whole different beast. They are infectious agents, but they're very different from viruses or bacteria. The word prion is short for proteinaceous infectious particle. They are basically misfolded proteins, specifically a protein called PRPC, that we all have in our neurons. And here's the scary part. Prions don't have DNA or RNA. They're just proteins that are misfolded in a way that makes them infectious. They even multiply by causing normal PRPC proteins to misfold into the infectious form, to be called PRPSC.
Okay, wow. So the misfolded protein goes around the neurons and messes up all the PRPC proteins so that they become misfolded just like it?
Yup, exactly. You got it.
Great. And I was also wondering if there's a connection between prions and mad cow disease.
Mad cow disease is actually a type of prion disease that is specifically seen in cattle, but it can spread to humans who eat contaminated meat. So the way that mad cow disease works is that basically the prion causes conformational changes in the normal proteins, turning them into infectious prions as well. All of these misfolded proteins build up in the brain and cause damage. Eventually, this damage leads to what is known as spongiform encephalopathy, which literally means the brain looks like a sponge on MRI.
Yikes. Okay, so mad cow disease is a prion that leads to spongiform encephalopathy. But that was in cattle, right? So what about prion diseases in humans?
Prion diseases are thankfully rare in humans, but if someone has them, they're always fatal and mainly attack the nervous system, where they cause spongiform changes in the brain. So basically similar changes to the ones we just mentioned in mad cow disease. These changes lead to dementia, atrophy of the brain, and eventually death. Some examples include Creutzfeldt-Jakob disease, Gretzmann-Straussler-Schenker syndrome, fatal familiar insomnia, Kuru, and Alpers syndrome.
Wow, those were a mouthful. Which ones should we focus on?
If you're going to remember just two of these prion diseases, then you should remember Creutzfeldt-Jakob disease and Kuru.
I think I've heard about Kuru before. Is that the one related to cannibalism?
Yeah, you're right.
Alright, let's focus on Creutzfeldt-Jakob disease for a moment then, and let's call it CJD. How do people get it?
CJD can either be genetic, acquired, or sporadic. The genetic form is basically an inherited mutation in the PRPC gene. The acquired form is basically the one you can get by eating contaminated meat or by performing medical procedures that involve infected surgical instruments, which we would call iatrogenic transmission. Then finally, the sporadic form is when sometimes normal proteins just randomly misfold into prions without a clear cause. In all cases though, once a prion appears, it turns all the other normal PRPC proteins into the infectious PRPSC form, spreading the disease.
Okay, and we said that it causes physical changes in the brain. Can we go into a bit more detail with that?
Sure. So prion basically forms fibrils that build up in the neurons. This leads to neuronal death by apoptosis, brain atrophy over time, and finally spongiform changes. This spongiform brain is basically full of holes and empty spaces on MRI. The key word here is conformational change. When prions force normal proteins to misfold, it becomes repetitive and unstoppable.
If it's so destructive, why can't we just kill prions like we do with bacteria or viruses?
That's one of the scariest parts about prions. They are extremely resistant to standard disinfection methods, and they aren't even always destroyed by high heat and strong chemicals. This is why they made very strict rules for disinfecting medical instruments if a prion infection is suspected. Prions can stick around on surgical tools and infect other patients.
Oh, that was the iatrogenic transmission that we just talked about, right?
Yes, exactly.
Okay, Lyan, I think we're good to go with encephalitis. How about a quick recap for encephalitis before we wrap up today's episode?
Absolutely, Alae. So, encephalitis is inflammation of the brain tissue itself, usually caused by viruses. It's more likely to cause confusion, seizures, and focal neurological symptoms compared to meningitis.
And the main viruses we're concerned about are the herpesviruses, right? They're DNA viruses that can go latent in nerve cells and reactivate later.
Exactly. HSV2 is a big one for newborns since they can get it while passing through an infected birth canal. Luckily, a C-section can prevent transmission if lesions are found on the mother before delivery.
Then we have varicella, which can cause chickenpox, shingles, and in some cases, even temporal lobe encephalitis.
Right. Treatment for HSV encephalitis is acyclovir, which is a lifesaver. For varicella, we have a vaccine, but unfortunately, there's no specific treatment for EBV encephalitis at the moment.
Speaking of viruses, after herpes viruses, we talked about Flaviviruses, which are single-stranded RNA viruses spread by mosquitoes.
Correct. And we discussed 3 main ones: West Nile virus, which is often asymptomatic, Japanese encephalitis, and St. Louis encephalitis. The last 2 have a similar high mortality rate.
And if I remember right, St. Louis encephalitis has no vaccine, while Japanese encephalitis does. So prevention is a bit trickier for St. Louis.
Exactly. Vaccination is key for Japanese encephalitis, but avoiding mosquito bites is the only real prevention for St. Louis encephalitis.
When it comes to diagnosing encephalitis, we've got the old school symptom-based method and a new molecular approach that's faster and more accurate.
Yup, the molecular approach is a game changer. It uses one sample to detect viruses, bacteria, and fungi all at once, cutting down on the wait for results.
And then we touched down on prions, those misfolded proteins with no DNA or RNA that cause fatal brain diseases.
Right. Prion diseases cause spongiform changes, dementia, and brain atrophy. Creutzfeldt-Jakob disease is the big one to remember. Genetic, acquired, or sporadic forms all exist.
And there's also Kuru, which is linked to cannibalism, if I recall correctly.
Yup, you got it. And prions are particularly nasty because they resist heat and disinfectants, making them nearly impossible to destroy.
All right, I think that covers it. Thanks for helping us break it down, Lyan.
Anytime, Alae. Glad we could tackle it together.
Perfect. That really sums up the essentials. Thanks, Lyan, and thank you to everyone for tuning in. Don't forget to leave us a review in the discussion below. Catch you in the next episode.